Professor at CREC in Cotonou, Benin. He has a PhD in malaria epidemiology and has devoted the past 3 decades to research on the major tropical diseases in Benin, guinea worm disease and also malaria. His current focus is on evaluation of the resistance of mosquitoes to insecticides and has conducted significant work to improve bed net strategies in Benin and beyond. Today he'll be talking about the impact of malaria vector insecticide resistance on the operational efficacy of LLINs in Benin.
Thank you. Good morning, everybody. Sorry for my English. Dear Chairman, I'm pleased to show you some results of a study conducted in Benin on impact of insecticide resistance on effectiveness of long-lasting net. As you know, for 2 decades, Africa has been confronted with the emergence of predatory resistance, and to face this phenomenon, 2 questions are often asked. The first, should we continue to distribute ITN? Should we continue to use ITN? It is a good question, but I think the answer is evident. The second question, does resistance have an impact on the effectiveness of ITN? What is clear today, studies have yet to demonstrate control program failure resulting from resistance. This is the objective of my presentation, is to assess the impact of predatory resistance on the effectiveness of long-lasting net. The big challenge of the study is the selection of the clusters. Due to the absence in Benin of areas where Anopheles gambiae is susceptible to penetrate, to be used as control, we classified and compared clusters of high resistance to clusters of low resistance. The studies were done in 32 clusters. The 32 clusters were selected in southern Benin, and we used 16 of the clusters for mosquito behavior identification and 18 for transmission indicators. But how we selected the 32 clusters? Initially, we tested 40 candidate clusters and we selected 32 based on Anopheles gambiae mortality in BioSA. And we considered clusters of low resistance, clusters where Anopheles gambiae mortality in BioSA is above 80%, and high resistance clusters where the mortality is below 60%. This is the first step of the selection of the clusters. The second step The clusters of low resistance are those where Anopheles gambia mortality is above median value, median mortality for all 32 clusters, and the high resistance clusters are considered where Anopheles gambia mortality is below the median mortality. Regarding the first part of the study, the entomological components, we collected mosquitoes using different methods: larvae collection and adult mosquito rearing to perform susceptibility tests and to study mechanisms involved in vector resistance, landing cache to determine indicators related to malaria transmission, exit window trap, and the pyrethrum spray cache to determine indicators related to the behavior of mosquitoes. Today, we gathered enough data we can consult in this paper. This figure shows Anopheles gambiae phenotype resistance to deltamethrin from 2011 to 2015. You can see a deltamethrin resistance varied across clusters, and also deltamethrin resistance varied between years from 2011 to 2015. In the study area, we collected 2 species of Anopheles gambiae complex, Anopheles gambiae sensu stricto and Anopheles colucci, and we found KDR occurs more frequently in Anopheles gambiae than Anopheles colucci. KDR West mutation frequency was close to fixation across most clusters and therefore had limited potential explanatory power. Therefore, all subsequent analyses were based on phenotypic resistance. Regarding the second part of the study, epidemiological studies, this part was organized around 4 methods: quad study to determine malaria infection in children through active case detection and through passive case detection in local health facilities. The second method concerns cross-sectional survey to determine malaria infection prevalence. The third is health facility data from health registry to determine morbidity and mortality due to malaria, and the last is case control study to know the effects of long-lasting net on malaria morbidity. We compared the incidence between clusters with high and low delta resistance by active case detection of cohort study. We can see the number of children recorded, the number of infection observed, and the rate of infection per child per year. This rate is the same for both high resistance zone and low resistance zone, and also for each year. In conclusion, we found no evidence of difference in malaria infection rate between areas with low resistance or high mosquito pyrethroid resistance. These results are illustrated in this figure showing the relation between malaria incidence and the level of resistance in terms of delta-methyl mortality. No evidence of an association between rate of malaria infection and mosquito pyrethroid resistance. During year 2014 and 2015, we found the same result. We compared infection prevalence between clusters with high and low delta-methyl resistance and between users and non-users of net. And you can see the malaria infection is the same in the low resistance clusters and in the high resistance clusters. We can see also that the malaria infection is higher in those who don't use ITN compared to those who use ITN. No difference, but delta-methyl resistance was associated with prevalence of P. falciparum infection. In conclusion, after 2 years of monitoring malaria incidence and a cross-sectional survey of malaria prevalence in areas with long-lasting net and pyrethroid resistance anopheles, we can retain 2 points. The first, no significant association detected between delta-methyl resistance and malaria transmission indicators or malaria infection. The second point, malaria incidence prevalence shown to be significantly lower in long-lasting net users than non-users. three possible explanations for the lack of significant association. The first is absence of zone with susceptibility of Anopheles gambiae to penetrate. I want to say absence of a good control zone. The second point is the sleeping behavior and ITN use are probably different from one cluster to another. The third point concerns environmental factors. We think that some parameters like woman biting rate and entomological inoculation rate are more influenced by some environmental factors like variability in the distribution of the breeding sites across clusters than the resistance factor itself. For supplementary data, you can consult this paper already published. I can't finish this presentation without thanking all the stakeholders involved in this study, particularly my collaborators of the National Malaria Control Program, CREC, the Faculty of Medicine, ARD, the Ministry of Health in Benin, the community of Plateau region in Benin, which is the study zone, Bill and Melinda Gates Foundation, WHO Global Malaria Program, London School, and Liverpool School. Thank you very much.